This is the fourth year that we have been required to account to the patients and the public for our quality performance. Many of you will be familiar that it's been quite common for many years for companies and businesses to present the financial reports and accounts in very much the same way. But this is now the fourth year that NHS bodies are required to do the same for their quality performance. And I'm going to give you a fairly brief overview of the headlines and the performance outcomes for that particular year. There's a lot more detail in the Blue Backed report that you have access to, and I'd be very happy to catch up with you at the end of the session if you have any specific queries or questions for me. So I'm going to touch on 2013-14 briefly in review, and over three quality domains. And the NHS definition of quality comprises patient safety, the clinical effectiveness and efficiency of our services, and also the patient's experience. Now, in terms of how do we come up with this list of things that we need to address and look into and improve upon, we consider a number of things, including our past performance. So what have we done well, what have we done less well, and what do we do particularly badly in? What are our development requirements? There are new techniques, new ways of delivering care, new models, new care pathways. And so how do we make sure we're up to speed with modern healthcare and modern processes for patients? There are clearly national priorities that are set for us, for the Government, Department of Health, NHS England, etc. Also, we talk to our staff about what are the things that they think we need to look to improve on and address. Stakeholder input's very broad, including people like Health Watch, our local authorities, our clinical commissioners, and others. And then, of course, our Council of Governors and our Trust Board. So quite wide-ranging consultation. And it's not just done at a point in time. We pick this up as we go throughout the year in terms of the things we're going to need to think about how to improve on. And as a matter of principle, it's important we set ourselves challenging and stretch targets, because if they were all easy to achieve, then that's not necessarily pushing us to be better and get better at what we do. And as such, therefore, we'll not necessarily always meet those objectives, although we should never lose our motivation to do so. So just touching on the safety domain first. And again, I'm sorry if you can't see this at the back. I've tried to make the font as large as I could, but again, happy to go through any specific queries you may have. The first one is in relation to patient falls. This is a particular challenge in a hospital environment. We are getting increasingly elderly, increasingly frail people. We're living longer, that's a fact. And when we look at the projections further into the future, we're going to be living even longer still, and more of us so as well. As we get older, regrettably, more things go wrong at the same time sometimes as well. And it's a fact that patients will fall in a care environment, especially where you are trying to rehabilitate people, whether you're trying to get them to a state of independence. And you can't always have somebody stood by every patient, obviously. And sometimes patients will get up and lose their balance, for example. So it's a specific and very focused area for us. And again, we continue to work very hard on this year as well. And there's a national measure that's around the incidence per 1,000 bed days. It's a technical number, but it's how you get better at that over time. And our ambition was to get to around or below 7.12. We didn't achieve it. We got 7.57, but that was much better than the previous year. So I can give you confidence that we've really continued to look at every single incidence of a patient falling. When it does happen, we undertake what's called a root cause analysis, where the doctors, nurses and others get together to really look at how that happened and what could we do to prevent that happening in the future. And did we also care for that patient properly when the fall happened? And again, we're seeing big improvements there. So by far from perfect, but a lot of work going into that particular indicator. And then the second one also relates to falls. Again, it's a deeply regrettable fact that sometimes when patients fall, they fall onto a hard floor surface and can sustain injuries. One of the most common in the elderly is a fractured neck of femur, your leg bone, your joint that goes into your hip. And again, we were trying to look at seeing if we can, through this falls reduction work, reduce the incidence of that particularly catastrophic harm. And our ambition was 34, we achieved 32. Whilst that's green, that's not something we're congratulating ourselves on. It just shows you numerically that there has been some marginal improvement, but again, the work continues. In terms of care of patients with dementia, we have agreed, and this rolls into this year as well, to develop a dementia pathway. touching on what I've just said about us getting older and frailer, if you like, there are more and more people being diagnosed with the many different types of dementia, a very debilitating disease in itself. And staff don't necessarily have all of the skills to be able to care for those patients. And also there's lots of research evidence to show if you do certain things within certain timeframes, people can hopefully rehabilitate much more quickly. We're on target to deliver that pathway by the end of December 14, so that work is progressing well. The Chairman's already talked to you about healthcare-associated infections, a big issue for us in the past, and again, we don't rest on our laurels as far as this is concerned. For MRSA bacteremia, again, the national, we don't call them targets, because you could argue we aim for targets. We don't aim to have infections, of course. So we call them ambitions, and the ambition for nationally for MRSA bacteremia is hospitals are supposed to have none. Now, statistically, nationally, you will always get between, even the research people say this, that you will get between 700 and 800 cases in the country. But the ambition for us all is to have none. We had one in 13-14, and that was deemed unavoidable. This was a patient who already was carrying this infection for quite some time and proved very difficult to treat. In terms of Clostridium difficile, again, a significant problem in the previous year. Our ambition, our upper threshold was 44. We ended the year with 27, the best performer in the Northeast hospitals, we were pleased to note. Again, we continue to see that positive performance so far this year as well. So that's really pleasing, but that's down to the hard work of everybody involved, all of our staff, in trying to reduce these very debilitating things when patients get them. Venous thromboembolism, or the common term, are clots. These are clots that can be stationary in your venous system or can pass and float through your bloodstream and block somewhere else. Again, can be catastrophic and are significantly debilitating for patients. And this was about making sure that we assess people on admission or when they're receiving treatment from us of the risk of getting this particular disorder. And the ambition is to achieve 95% of patients getting that screening, and we finished the year with 96% of patients getting that screening. Sometimes it's not possible to do that immediately quickly, hence there's a little bit of a tolerance for that. But again, positive performance. Pressure ulcers, these are when people get ulceration in the skin and deterioration and breakdown in their tissues if they have sustained pressure in given parts. And sometimes these can be indicators of poor care or inappropriate care, care planning and care delivery. Grades 3 and 4 are particularly significant pressure ulcers. That's when the skin breaks and the fat layer breaks and you get serious tissue deterioration. And that's, again, significantly debilitating for patients. Again, we're not perfect at this. We've still got a way to go. And we've adopted what we've called the zero tolerance to this. And our ambition, therefore, is 0. So that's a very tough objective. And the outcome for the year was 7. That was much better than the 20 so we had the previous year. So again, an improvement, but far from perfect. A lot of work still to do on this, and that work also continues. Discharge summaries, this is when a patient leaves our care and goes back home or back to their normal place of residence. And this is where we are required to get a letter to the patient's GP to tell them why they've been in hospital, what's happened to them, what medications they're on and what aftercare they need. Again, fundamental for the continuity of care so that GPs understand why somebody's been in hospital. We've struggled with this one. We've continued to struggle, but for the last year, you'll see the ambition was 95% of patients to have these to the GP within 24 hours. We didn't do well in 13-14 at 86%. That meant that 14% of patients, GPs, were not getting their letter within 24 hours. We're now averaging between 90 and 95%, so it's coming up steadily, but nowhere near where we'd like it to be. So this remains a continued focused area that we consider weekly and, in fact, monthly through our various mechanisms in the organisation. So seeing some improvement, but nowhere near where we want to be yet. The development of a discharge going home guarantee. This is about making sure that we've done everything that we should do before somebody goes home and to their place of residence. So if they need support care, a care package, or something similar, home adjustments, for example, that they're all attended to before someone goes home. We've developed this guarantee. That was what that particular target was meant to achieve. It's now measuring how well we do against that, and we're doing that this year. In terms of patient safety incidents, This is about when we report when something has gone wrong, or where there's been some harm, or even a near miss. So that can cover a whole host of things. I've talked to you already about when a patient falls, we would report that as a patient safety incident, that the patient has fallen, and whether they subsequently get any harm as a consequence of that fall. Other examples of patient safety incidents are if we give somebody the wrong medication or the wrong dosage of medication, for example. So these are things that sometimes are preventable, quite often they are, sometimes they're not, but still we should be reporting them. Also, if you have a good safety culture, then you should be reporting a lot of near misses, because it says we're not frightened to say this nearly went wrong, and if we don't do something, it could cause harm in the future. Now, there's something called the National Reporting and Learning System, or NRLS, and when we enter a patient safety incident onto our computer system, it's uploaded periodically into a national database. And once you've entered it, you can't take it off. It's there in the system. And the ambition that will tell you whether you're a good reporter is to be in the top 25th percentile. Sorry, the 75th percentile. You will see that that was our ambition, and in the year we only got to the 50th percentile. What I'll say to you is that in the previous year we were only in the 25th percentile, so we were in the bottom 25%. We've come up to the middle, and we're hoping that we will continue to get further and further. So still a lot of work to do there about reporting incidents and also then acting on them to make sure we learn and improve care for patients. Touching now on the patient experience domain, apologies, these are quite small, but these 5 all relate to nutrition and hydration. Really important, we need the fuel in our tanks, otherwise we won't get better and heal. And there are 5 indicators there. The first one was around screening patients at nutritional risk. We set an ambitious target, and that is very ambitious, at 98% of patients being assessed within 8 hours. We achieved 96.7, so we didn't quite get that, but again, we haven't met what we set for ourselves, so that continues. In addition to screening on admission, we screen patients weekly, or we should. And again, we didn't meet our 98% target. We only got 90.9%, so room for significant improvement there. We've changed our documentation recently. We're just about to launch a new version of this to see if we can get people to make it more user-friendly, to complete fully and properly, and we'll see how that goes. That goes live on the 3rd of November. Having a plan in place for those who are at nutritional risk, again, so if you are at risk, you should therefore have a plan to address that so that everybody knows the type of nutrition that patient should be getting. Again, we set ourselves a 98% target, tough target, but we only achieved 92.3, so still work to do there. Evidence of food intake is really the ultimate measure. One would suggest that how much food has somebody actually taken. Getting it to the patient is one thing, making sure they've eaten it and have eaten sufficient of it is another. And we set ourselves a 90% challenge there, and we achieved 93.7. So we've upped that challenge this year. And completed fluid balance chart, this is on someone for whom we would need to measure how much fluid they're taking in and how much fluid they pass out of their body, because sometimes that imbalance, if it is imbalance, can cause problems for people clinically. And again, we set an ambition of getting that right 90% of the time, and we didn't achieve it at 89.7. So that continues to be an area of focus this year as well. So you see a pretty mixed bag there. The end-of-life care pathway, this is a significant area of focused attention for us. Many of you will be familiar with the term Liverpool care of the dying pathway. Well, that now has been taken out of use in the National Health Service. It achieved a lot of publicity nationally in terms of not being necessarily always a good thing to place patients on. And this is when a patient is known and considered to be in the dying phase of their life. I think it's fair to say we also at County Durham and Darlington NHS Foundation Trust haven't always got this right. In fact, sometimes we've got it very wrong. And especially when we haven't necessarily communicated with the patient about this themselves and or the patient's family. And that causes a lot of distress and anxiety, completely understandably. So what we're trying to do now is we are joining forces with our clinical commissioners, our GPs, our local authorities and the ambulance service and other stakeholders. And we are all adopting what's called the Deciding Right guidance, the new set of standards developed in the North East that replace effectively the Liverpool care of the dying pathway standards. And our launch date for that is the 8th of October at the Excel Centre. And so again, we'll all be getting together to talk about then the training and the underpinning that now needs to take place to make sure everybody knows knows how to use these properly so that patients at the right stage of their care pathway get the most appropriate care, and that relatives also get the most appropriate care and information where that's necessary and appropriate to do so. And part of that is sometimes it's in the patient's best interests and with the patient's consent where appropriate to discuss with them whether you would actually resuscitate them in the event of them stopping breathing or their heart stopping. And this is called a do not attempt cardiopulmonary resuscitation order. And again, we've had variable performance on this. Sometimes we've got that right, but sometimes we've got it very wrong. It's about us acknowledging that, admitting that, and looking at what we need to do to learn to get better at this very, very important thing. Another standard was the development of a learning disability guarantee. This is about making sure when we have people with learning disabilities, and they access all of our services, of course they do, making sure that we have people trained to the required standards to understand the needs of people who can't necessarily articulate their needs for themselves. And it's how we get better at working with those people to understand their particular needs when they come into our care environment. And so the Learning Disability Guarantee is about the conditions we will aim to agree to meet with any patient that has a declared or known learning disability. And again, we've developed the standard, the guarantee. This year, we're looking at how well do we do against that standard. Responding to patients' personal needs. Again, this was about how responsive are we to them, and again picked up from the national surveys. We had an improved result on 4 out of the 5 indicators, which gives you an achieved score. Again, doesn't mean to say we're complacent about that. We're absolutely not. It's only ever as good as the point in time a survey is taken, of course. And so therefore it's important that we don't just rest on laurels with these sorts of improvements. It's about looking at all of our patient satisfaction scores and seeing how responsive we are to them. And also making sure that we learn from complaints when we have complaints about care. And we do have a number of complaints where we still have to work to improve and get better in response to. Our staff experience is equally as important. The chairman talked about our 8,000 staff. Well, we believe firmly that if you've got happy, contented, well-developed staff in the right numbers and the right distribution, you're much more likely to get better patient care and outcomes as a result. And one of the measures is the percentage of staff who would recommend the trust as a provider of care to their friends and family should they need care in our environment. And again, I think it's fair to say that we've seen some improvement, but we've not met the ambition that we've set for ourselves. The national score for this, the national average, is a score of 3.68 out of 5. In 13-14, we only scored 3.55, so we didn't meet that, at least the national average, or better than. But that was an improvement on the previous year of 3.41, so there is a steady improvement. Let's hope we can continue to see that improvement over time, but again, not where we wish to be. In terms of clinical effectiveness, again, risk-adjusted mortality. These are technical measures that measure death rates in hospital. And risk-adjusted means that it's supposed to be comparable because it takes out any undue risks that may skew results. And again, there are 2 key indicators that are looked at here. The first one is called RAMI, or the Risk-Adjusted Mortality Indicator, and the SHIMI, which is the Standardized Hospital Mortality Indicator. And again, as long as we meet these within a reasonable tolerance, or the as-expected levels, and again, we can take you into more detail should you wish to know more about this. For the RAMI, April to December, because that's the date that they measure it over, we scored 89, and for the SHIMI, we scored 104.3. So they are within the expected ranges for those 2 indicators for that year. Compliance with stroke pathways, the chairman touched upon this again, and I know has been a significant issue for many of you in the past in terms of where the services were distributed across our organisation. Again, all of those standards have been met within the expected thresholds. I won't go through those, you can see them for yourself, but again, we've continued to deliver good performance in relation to each of the stroke pathway indicators. Readmission to hospital, this is a particular challenge for us. Again, this is about how we reduce readmissions where patients are discharged from our care, but then come back into our care within 28 days. And our ambition was set at 7% of those patients, or fewer than. We've achieved a 12.3% rate, so we did not meet that outcome. And again, this is for a number of reasons. It's about how we understand why do people come back to us. Is it that we discharged them too soon and they weren't fully ready to go home? Is it that we didn't put the right support services in for them when they went home? It can be for a multitude of reasons, and it's about how we learn and understand. I don't think we were particularly great at this. We're getting better at it, but we've got a long journey to make sure that we can deliver improvements in this area. And then the emergency department indicators, or the accident and emergency department indicators. Some of you will be more familiar with some of these. There are a number of these. The first one is time to initial assessment. This one was where we achieved that initial assessment within 15 minutes maximum. In 13-14, we really didn't meet this by a long stretch. We only achieved an average of 49 minutes, which is woefully lacking. Time to treatment decision, though, we achieved. So once somebody's been seen and then getting a decision about what was going to happen to them, we achieved that one. So clearly the area of focus is about seeing people in a timely manner for the first assessment. And then unplanned emergency department reattendance. So this is people who come back to the emergency department with the same issue. And again, this is to achieve less than 5% or fewer than 5% of people doing this. And we achieved this for a level of 0.6, which is really quite positive. Left without being seen is a national term. Some people come to an accident and emergency department, book in for treatment, and then go before you've had a chance to see them. And again, to make sure that we can improve and make sure we don't have anybody at risk leaving our organisation who hasn't been seen, the national ambition is less than 5%, and we achieved that with only 1.7% of people. And then the 95%, the more commonly known A&E target, and this is about 95% of people being treated, admitted or discharged from the emergency department within 4 hours. We just missed that by a whisker at 94.9% last year, so we did not meet that objective. And the Chairman's already talked about these continue to be pressurised areas for us at our emergency departments. And then patient-reported outcome measures, or PROMs, and this is where we ask people who are going through specific types of surgery, so planned hip, knee or hernia surgery, how do they feel? What are they like before their operation? So what are the limitations this condition gives them? And then 6 weeks or 3 months after they've had the operation, has it worked for you? So for example, if you need a knee replacement, has it improved your quality of life or not? And PROMs are set to determine the level of improvement following the procedure or the treatment. And again, ours was to improve our participation rate so that you get good information. And we achieved some improvement in that, but there's been a way to go. I'm pleased to say they are much more online this year, and we'll report those back next year. So in summary, lots there, and I appreciate this is a quick canter through. We've made lots of improvements, but still a great deal to do in areas where we're not doing well, or we haven't done as well as we set for ourselves or were set for us nationally. And so we continue to try and push ourselves and stretch ourselves further and get better at what we do. So we're on a journey of continuous learning and continuous improvements in order to improve patient care and their experience. Thank you for your time.